we'll go on to the next topic. The next topic is pubertal disorders in girls. And Kumaravel is going to talk on this topic. He has been a student of Madurai Medical College. He did his MBBS MD in Madurai Medical College, DNB Endocrinology from Kochi, and he is currently the director and consultant of Alpha Hospital, awarded honorary professor of IMA CGP New Delhi. He is the vice president IMA Madurai branch, president of Endocrine Society of Tamil Nadu. He is the course director in FCE organized MA CGP. He organized many national conferences, and he has been regularly conducting this program every year and published in national and international journals, and has contributed to in revised IAP growth chart. And over to Kumaravel. He is the son of the soil.
Thank you, sir. Thank you so much for your kind words. And I would say these pubertal disorders are a very common problem for the patients and the family, but unfortunately it's the most neglected problem for the physicians or doctors. And at one end, we see a patient presenting with puberty less than 8 years. Another end, we are seeing patients who are presenting with puberty or who are not attaining puberty more than 14 years. So we have two major spectrum. But many times what happens is whenever you see a patient who is coming to you with early puberty, first thing what happens is, even the family says, "Unga party vema vayasku vandanga, unga atta vema vayasku vandanga." So it is ignored. And another spectrum, they say, "Unga veetla ella late ah dhaan vandanga, so you would come." But what happens, what they say might be 90% right, but 10 to 20% might have a hidden problem which definitely requires a treatment. The reason why I'm saying it is neglected among physicians is that when you try to see yourself in the angle of the patient, you can see the amount of psychological turmoil which the patient would be facing. Because at 8th standard, all the peer group or all the classmates, they attain menarche. There are only 3 or 4 children in the classroom who do not attain menarche. So this gives a lots of psychosocial pressure among the students or the children. So you would have been seeing so many patients, 8th class varaikku nalla dhaan padicha sir, 9th 10th enna achinu theriyala. So these are some things could be related to pubertal disease, which I am sure as a physician or a practicing doctor, which is very much important for us. So in this context, this is the overview of my talk. I would try to give you an overview of what exactly is puberty is, and my talk would be focusing more on pubertal disorder in females. When I say pubertal disorder, it could be a delayed puberty where puberty occurs late, or it could be a precocious puberty where your puberty occurs early. So these are the 3 spectrums which I would like to discuss today. I would not go in depth to the treatment, but I would say how do your diagnostic approach, like a thumb rule, how it could work in your day-to-day practice. So puberty is nothing but it's a process of acquisition of secondary sexual characteristic, which is associated with growth spurt, which ultimately results in attainment of sexual and reproductive function. So from a child, you are transitioning to adulthood. So when you transition yourself from childhood to adulthood, what happens? You develop your sexual and reproductive maturity. So first and foremost, what happens is there's a maturation of your primary sexual characteristic. What is your uterus grows, your ovary enlarges. So this is what is called a primary sexual characteristics. Then you have a development of secondary sexual characters. In a female, you have a breast enlargement, you have a relative fat distribution, you have female contouring, all those things happen. Growth spurt, generally females grow roughly around 20 centimeters during the puberty, and after puberty they don't grow. So any interventions to increase your height or stature, if feasible, should be done before puberty. Nothing can be done after puberty. And most important is psychological maturity. So you develop maturity, how to handle a situation, how to move with people, everything happens during this puberty. So it's a transition where so many factors happens in puberty. And again, when I say transition, there are 3 major events which happen. One is your breast development, what you call is a thelarch. And second, your pubic hair development, what you call is adrenarche. And finally, you have a menarche, which is the onset of your menstrual cycle. And of course, you have a growth spurt which happens with this. The whole sequence of this puberty takes roughly around 1.5 to 4 years, depending on the individual and the genetic potential. So the various somatic changes which happens, And it is very, very important for us to understand the staging of your pubertal development, because only by knowing the stage, you would know whether the child is progressing in puberty, because everyone would say the child has a small breast enlargement. So what is small is highly subjective. So unless you have a pubertal staging, you have various staging, like you have stage 1, stage 2, stage 3, stage 4, stage 5 for breast. Stage 1 is prepubertal breast, and finally stage 5 is the adult breast with areola and breast having a smooth contour. So it traverses from stage 1 to stage 5, which becomes your adult breast. So similarly, your pubic hair, in children, you don't have any pubic hair. Then you have a pubic hair. Depending on the amount of pubic hair, you have various staging which is there. Again, you have axillary hair, and finally you have menarche, which is possible. So these are so many events which is seen outside or visible outside for us during the puberty. And of course, there are so many other changes which happens inside. Like you have a uterus which enlarges, you have ovaries which enlarges in volume, ovaries become multicystic, your egg starts forming, and similarly your vaginal contour changes, your vaginal flora changes, everything happens. But what determines your sequence of event which is happening internally and externally is your hormones. And these hormones are nothing but hypothalamo-pituitary ovarian hormones. So your ovary secretes a hormone called estrogen and progesterone. Basically what happens, your hypothalamus secretes a hormone called GnRH, or gonadotropin releasing hormone. The same hormone drives your pituitary to secrete LH and FSH depending on its frequency and your pulse amplitude. And your GnRH in turn acts on your pituitary to secrete LH and FSH, which in turn acts on your ovary to secrete your estrogen, which is responsible for your secondary sexual characteristic and maturation of your primary sexual characters. And again, these hormones are responsible to cause your ovum growth, and that's how your whole puberty sequence starts. And of course, you have a negative feedback. Your hormones from ovary, especially estrogen and inhibin, can act on your hypothalamus, and thereby they can suppress your LH and FSH. So basically, whenever you have abnormality in hypothalamus and pituitary, this axis is similar to your thyroid. Whenever you have abnormality in hypothalamus and pituitary, your LH FSH is low and your estrogen is low. Whenever you have abnormality in ovary, your estrogen is low, negative feedback is lost, so your LH and FSH hormones are high. So this puberty is basically centrally driven, and what you say is hypothalamo-pituitary gonadal axis. You have growth hormone, you have thyroid, and other gonadotropin secretion. Of course, this puberty depends on your general health, your nutrition, your exercise. Exercise trainers might have delayed early puberty. You have genetic influence, you have race, socioeconomic condition, and many times this puberty is programmed from an intrauterine environment. So IUGR babies or small for gestational age babies, they can have altered pubertal development and presentation. So abnormalities in the process of sexual maturation, you have precocious puberty and delayed puberty. These are the two spectrums which we commonly see. And when I say it's precocious puberty, you have true precocious puberty where your problems is in your hypothalamus pituitary. So that drives a pituitary axis very fast. Another thing, you can have a peripheral precocious puberty where your problem is in the ovary. Apart from that, you can have various incomplete precocious puberty where a patient can present only with breast enlargement. A patient can present only with adrenal, they can present only with pubic hair, or they can present only with axillary hair, and you can have a patient with no secondary sexual hair but only with menarche. So various permutation and combinations are possible with this precocious puberty. Another spectrum, you have a delayed puberty where you can have a problem again with your pituitary gland or again with your ovary, and sometimes your hormones are normal, still you don't get periods. What you call eugonadotropic eugonadism, where you can have a problem with your uterus or your endometrium. So these are in a nutshell how puberty happens and what are the deviations which can happen from a normal sexual maturation. With this, I think I will take you to some small case series so it is easy for you to understand. So here you have a 16-year-old female presenting to us for not attaining menarche. So you can have 4 scenarios. So case 1 is 16 years, and A1 is no axillary hair, B2 is a mild breast enlargement, and P2 is just few pubic hair. So this is, we can say, just the start of puberty, or it's a very, very early stage of puberty. Her height is 142, which is slightly low for a 16-year-old. You expect at least 150 centimeters. And mother had a history of delayed puberty. And case 2 is similar picture, but the mother had a puberty at the normal time. Case 3, you have a similar picture, but height is, the child is short. And case 4, again, your secondary sexual characters are normal, but still puberty is not happening. So when you try to look at case 1, case 2, case 3, you have 3 set of patients who has not attained puberty at the age of 16 years. And case 4 is, this patient has features of secondary sexual characteristics but not attained puberty. Now, how do you define delayed puberty? Say delayed puberty, one you can define by onset or you can define by progression. So whatever definition you look at it, all 4 patients have a delayed puberty. First 3 patients, they have delay in onset. There is not much of secondary sexual characteristic. And patient 4 has all secondary sexual characteristics, but it does not progress to menarche. So all 4 patients would quantify for the definition of delayed puberty. And delayed puberty in females is defined as absent secondary sexual characteristics by age of 13 years. In male it is 14 years, in females it is 13 years. So all delayed puberties need not be same. So the etiology of delayed puberty, one is constitutional. As I said, this is very normal. உங்க வீட்ல எல்லாரும் லேட்டா வயசுக்கு வந்தாங்க, நீங்க லேட்டா வருவீங்க. So it usually runs in family. So positive family history is very important. Many times the constitution delayed puberty is associated with short stature. So usually they may be short. And second thing is hypergonadotropic hypogonadism. So these two terminology might sound French and Latin for you, but basically what you have to understand, hypogonadism means your gonads is not functioning properly. Hypergonadotropic hypogonadism means your LHFSH is high, which is driving to push your ovaries to function better. So hypergonadotropic hypogonadism is also called primary gonadal failure, and hypogonadotropic hypogonadism is also called secondary gonadal failure, where your problem could be in the pituitary. And fourth spectrum, your gonadal hormones could be normal, but still you don't have menarche, which is happening in our patient. So apart from the various clinical histories which is useful in our practice, one, you look at the age of puberty initiation, when did the breast enlargement happen, when did the axillary hair happen, look at the neonatal history, what is the birth weight of the child, look for other medical condition, because whether the child is taking any other hormones or any preparations, look for surgical history, the child would have had some trauma, ovarian cyst, surgery would have been done. Look for other medications, chemotherapy, radiation. Most important is family history. And always look for other Turner stigmata or hypothyroid features in patients with delayed puberty. Because Turner syndrome is one of the most common cause for delayed puberty, presenting with hypergonadotropic hypogonadism. The special investigation, the common test, what we do is a LH, FSH, estradiol. Sometimes you can go for a stimulation test. Of course, thyroid function test, prolactin. And chromosomal studies would be done for selected patients. And radiological, you look for a bone age study and ultrasound abdomen and MRI. Now applying this thing to our patient, case 1 is no secondary sexual characters or very minimal secondary sexual characters at the age of 16 years, not attaining puberty, height is 142. And one test, if you ask me what to do, you look at the bone age. So this is a patient with delayed puberty, with delayed bone age, and with a family history of delayed puberty is most probably constitutional delay in puberty. So many times these patients may go through the puberty normally, but again this thing has to be differentiated with hypogonadotropic hypogonadism, because most of a clinical picture would be the more or less similar. So these patients should be kept in the follow-up, and if it's 16 years, many times you end up giving or initiating puberty for this individual, but the same individual has been 13 years or 14 years, it could still be a constitution delay in growth and puberty, which is the most common cause what we see in the practice. So the second patient, again, you will see there's no secondary sexual characters, family history of delayed puberty is not there, bone age is normal. So this bone age is at par with the age of the child. And then whenever your bone age and all this is normal, you look for gonadotropins, LHFSH is high. So that is the reason you call it hypergonadotropic, estrogen is low, hypogonadism. So this is a case of primary gonadal failure. Most common cause is Turner syndrome. So your gonads are not functioning. So you look at it, so you can see webbing of the neck, and what you see here is just a 45 chromosome, one chromosome is missing. So this is 45X chromosome, which is a Turner syndrome, presenting as delayed puberty. So now the concerns in Turner syndrome or any patients with delayed puberty is that your height you look at the age of the patient, you look at the height potential, you look at various psychological and bone mineral acquisition. So these patients use your pubertal initiation should simulate your normal puberty. Usually you start with estrogen, you slowly increase your dose of estrogen at least for 2 years, and then only you induce puberty. Many times we see whenever you have delayed puberty, you give some injection, the patient attains puberty. It's not like that. So your uterus should grow adequately. Your breast should have adequate glandular tissue, then only your breastfeeding would be normal, your childbirth would be normal. So adequate estrogenization is very, very important in a child before your progesterone has been introduced. So these patients, you start with low dose estrogen, slowly build up, and after 2 years, or when your breast has reached Stannis stage 3, or when you have breakthrough bleeding, you add progesterone. Otherwise, nothing would be required for this patient if it's a constitution delay in puberty. So next patient, again you can see your pubertal development is not there, but the important catch here is a patient is a short stature. So short stature with delayed puberty, first and foremost is Turner syndrome. Short stature with delayed puberty, with delayed bone age, most probably it's hypothyroidism. This is something very, very common which is missed in the clinical practice. So this patient, you can see all your hormonal profile is something related to your hypogonadotropic hypogonadism, but your TSH is more than 100. Treatment is simple. You just treat your thyroid function. This patient will undergo a normal puberty. No other investigation or no other treatment would be required for this patient. So these are the 3 kind of patients which I have shown, all presenting with delay in onset of puberty. One is a constitution delay, another is a hypergonadotropic hypogonadism, which is a Turner syndrome, another is a hypothyroidism. So there are 2 clinical points which really helped me to reach this diagnosis. One is a family history of puberty, and second is the bone age. So based on these 2 itself, we would be able to diagnose exactly what it could be, and then you confirm your diagnosis with various investigation. Case 4, you have a patient, normal puberty, normal family history, normal stature, and normal bone age, normal hormones, still no puberty is there. So this could be a case of Mullerian agenesis where your uterus is not there. The reason why these things has to be diagnosed is in this patient Mullerian agenesis, the next thing your patient wants, what would happen to the childbirth? So in Mullerian agenesis, they can go only for a surrogate mother. In hypergonadotropic hypogonadism, your uterus is there, you can go only for ovum donor. If it's a constitutional delay, they can have a normal fertility. So establishing diagnosis is very, very important for us to counsel the patient regarding your future progress. So next, I'll just move to the another spectrum of the disease where you have a 2-year-old child presenting with breast enlargement, which is gradually increasing, no axillary or pubic hair, no vaginal bleeding. You have another spectrum, 6-year-old child, similar breast enlargement, but having a growth spurt, sweat order, but no axillary and pubic hair. And again, you have a 8-year-old child presenting with breast development, no growth spurt, no axillary or pubic hair. So you can see all these children presenting with your breast enlargement. So now when you try to look at what exactly are these, so whether it could be a precocious puberty, or when do you say it's a precocious puberty? Precocious puberty is defined as appearance of secondary sexual characteristic less than 8 years in girls. Whenever you have secondary sexual, whether it could be a breast, or whether it could be a axillary hair, whether it could be a pubic hair, or whether it could be a growth spurt, whatever it is, if it happens to less than 8 years, you call it a precocious puberty. So the second thing in precocious puberty, what is the etiology of precocious puberty? So whether it is the hypothalamus and pituitary which is driving the whole gonadal axis going fast, or whether is my ovary alone is secreting more and more of estrogen. So based on that, you call it either gonadotropin dependent, where your problems is in your brain or pituitary, or gonadotropin independent when your problems is in the ovary. So history, again, one important history which is very important is onset and progression of symptom. I told you even in the first slide, your progress of puberty, you have a growth spurt, you have breast enlargement, you have axillary hair, pubic hair. So when it follows a sequence of events, usually it is a central precocious puberty. When it does not follow the sequence, you just have a breast enlargement alone. When you just have a adrenal hair alone. So all these things, when it does not follow the sequence, it is mostly peripheral precocious puberty or gonadotropin independent precocious puberty in most of the patients. And again, one test which really helps here is your bone age. So in precocious puberty, you expect your bone age to be advanced. So when you have a bone age which is normal or bone age which is delayed, which could turn your diagnosis totally upside down. So now what happens to our patient? So the first patient, bone age is 2 years, which is at par with your chronological age. Your LH, FSH, estrogen is normal. Your thyroid is also normal. So it is just a premature TLARC where this patient does not have a growth spurt, does not have a menarche, does not have other secondary sexual characters. It's a premature TLARC, which is a variant of a normal precocious puberty. You just have to follow it up. Second, you have a patient with breast development, growth spurt, bone age is also advanced, and all your gonadal hormones are in the pubertal range. So this is a very classical case of central precocious puberty, which has to be treated. Third, you have a patient with breast development, but the bone age is delayed. We said whenever you have precocious, bone age should be prolonged. So this patient bone age is delayed. Again, this is a case of hypothyroidism, which is presenting with polycystic ovaries, delayed bone age, precocious puberty. One thing which you have to remember is hypothyroid can present both as delayed puberty and both as a precocious puberty. The way it which happens precocious puberty is that whenever you have a low T4, TSH is high. This TSH in turn acts on your LH receptors in your ovary becomes enlarged, it secretes more and more of estrogen, and then it leads to a precocious puberty. So objectives of management would be to maintain height, prevention of emotional disorders and handicaps, reduction of sexual abuse. So this patient is a child Lina, 5-year-old, 6 months, presented with precocious puberty, diagnosed with pregnancy. This is the earliest pregnancy which is reported in literature, where this child has a precocious puberty which was undiagnosed, sexually exploited, becoming pregnant. So this is one of the major concern with precocious puberty. One is the social problem, second is your sexual problem which could happen. I think I will stop with this. Just to conclude, pubertal disorders, both early and delay, are not uncommon, and constitution delay in growth and puberty is the most common cause of delayed puberty. Focused examination and evaluation is required, and bone age is a very, very useful initial assessment in all cases of puberty. Height potential, psychosocial factors, and sexual abuse has to be considered before treatment. And thank you so much for your attention.
Thank you, Dr. Kumaravel, for a lucid presentation. And very often, as physicians and practitioners, we also tend to feel the same way. Everybody in your family has occurred the same way. It is a delay or a early puberty. It runs in families. That's what we usually say and encourage them. But we have to pick up the right cases which require treatment. That is the whole point in this. If you have any questions, you can ask the speaker.
Yeah, bone age, there are two. Generally, you try to look at the X-ray of your hand, sir. Usually, we take it a non-dominant hand. So usually, for right hand, you take an X-ray of left hand, because that is the only X-ray where in a single section, you will be able to see 20 bones. Similarly, you could see the X-ray of the foot also, but most of bone overlap. So looking at the X-ray of the hand, you would be able to say what could be the bone age, because each carpal bone appears at a particular age. So counting at the number of carpal bones and counting at the lower end of the epiphysis, ulna and radius, you will be able to see the bone age. You have bone age chart is available. Grulich pile chart is available. You can just have a bone age chart and you can just compare your X-ray with this chart and see where it exactly matches. So that could be done in your busy clinical practice. You can have your bone age chart. But when you're seeing so many X-rays, you might be just see the X-ray and you may be able to tell you the bone age.
That was a wonderful presentation. Actually, being a pediatrician, we are seeing a lot of cases of such pubertal problems. As you said, it's not like uncommon. They are common. We are seeing it. Actually, a lot of mothers are asking me one question, and I went into net, and it was a old one. What they asked and what I found out, the puberty, the onset of puberty, in Europeans, they are meticulous. They have records for everything. They found, what it is found out in 1850s, the onset of puberty, the mean age is around 15 to 17 years. Even in Europe, it must be in Asia also. So now what they found out, by 1950, the onset of puberty is around 12 to 13 years, and now it is around 9 to 10 years. We are almost close to that precursor puberty definition. So what the mothers were asking, why this is happening nowadays more and more in our children? Why my child has come to age by 9 years? It's like they are telling we attain the age at 12 or 13 or 14, something like that. So is there any, no, I'll finish. What they are asking, is there any relationship to chicken, eating chicken and all these, mutton, everything, because people are eating nowadays, their socioeconomic standard has increased and they are eating. Is it related to broiler chicken? Is it related to use of hormonal substances in all those, this animal husbandry? Yeah. That's my question.
So the 2-3 reasons which has been posited. One, what you call as a secular trend. Nowadays, the overall puberty itself is coming early. That's one. And the reason which has been postulated for secular trend is for most of a puberty, you require a critical fat mass. So basically, as I said, puberty is a transition from your children to adulthood, which gives you a reproductive potential. So for you to reproduce, you require adequate fat mass and other things. So the leptin has been postulated. When you have adequate fat mass, it acts through your pituitary. It triggers your pituitary. So your fat mass triggers your pituitary. So nowadays your nutrition has increased. So your pituitary trigger starts earlier. So this is one hypothesis. Second hypothesis to your question of your chicken. So usually estrogen, they are all gonadal hormones. They can precipitate or they can start your pubertal axis, which can again start. So one thing which has been, I would not say it is due to chicken. There's something called endocrine disruptors. So there are various environmentally happening endocrine chemicals, most commonly diethylstilbestrol, or you have various polychlorophenols, polychlorobenzene, which is seen in everything. Even your non-stick pan has some kind of PCBs, and most of your lipsticks, most of your shampoo. I think now you have various controversy with shampoos also in media. You have various kind of Dove shampoo, what has been happening. So all these things, they have some amount of content which can mimic your estrogen, which can act on estrogen receptor. And third thing, if you take estrogen itself could precipitate, because there has been so many studies which are looked at the broiler chicken, all those things, they contain high amount of estrogen, which in turn could precipitate a hypothalamo, pituitary and your ovarian axis. So these things are definitely possible.
Any studies regarding the difference between the rural area and urban population? You might have seen patients from rural area and urban. Any difference in onset of puberty when compared to rural area to urban?
So usually, at least with preliminary studies, what we have done, what we have found, in urban, your puberty age is at least a year earlier compared to the rural. So that we have seen. But again, rural obese, urban obese, your age of onset of puberty is more or less same. But otherwise, generally, urban, they have at least 1 year earlier onset of puberty.
Steroidal chicken could be the reason for this?
No, it's not a genetic modified either. Basically, what they say is any preparation which has a estrogen in it, which could be something related to any estrogen preparation, like more than chicken, there's a soya protein is there, meal makers are there, and even it's a genetically modified chicken. There have been studies which have shown, which have measured the estrogen content in of the normal, what is a natukoli and broiler coli and genetically modified chicken. They have seen the estrogen content is slightly variable in these things.
No, that estrogen is present as well as in the plant.
Yeah, anything.
Too.
It could be either phytoestrogens or it could be any kind of estrogen derivatives. So any kind of estrogen derivatives, basically any, it contains cyclopentanone perhydro ring, which can interfere with your gonadal axis. So these are basically hypotheses. So as I said before, most of the endocrine disruptors are very, very fascinating to discuss, but it is very, very difficult to prove.
And how about the hormone insulin? Like insulin resistant, it induces the insulin growth factors, which will give the early stages of breast development, axillary hair and all those things, no?
No, basically, madam, most of the, when you try to look at insulin resistance, it has hyperinsulinemia. So your systemic insulin levels are very, very high. So these insulin, they can act on various factors. So one hypothesis, these insulin, they act on your ovary, and it can cause polycystic ovaries, and especially they act on your ovarian stromal cells, And because of the polycystic ovary, you have a hyperestrogenic state which can precipitate precocious puberty. So this thing is possible. Insulin directly may not cause puberty, but insulin, by its effect on growth promoting factors, it acts through your ovary and it causes all these changes. But your insulin levels, again, they cannot directly act on your breast and it cannot cause breast enlargement.
Yeah, it will not.
For you to have breast enlargement, you should have either estrogen, progesterone or prolactin to act.
Now, again, the adipose tissues, no, the fat deposition, it is also because of insulin. So, insulin, one thing is reduces the glucose level as well as it stores the fat in the body. So, what we get the subcutaneous fat or the visceral fat deposited, it is all because of the insulin, too much of insulin. Then again, hyperinsulinemia and insulin resistance. As sir was mentioning about ghrelin and leptin, so the patient who have ghrelin, when they start eating, when they have the hunger hormone, they start eating and the leptin comes and it gives the satiating power. If the patient have leptin resistance, then where is the stoppage for the food? And the food what we eat nowadays, everything is producing more glucose. Again, for the more glucose, more insulin has to be secreted. So hyperinsulinemia is a very common for everybody.
No, madam, I think
No.
the hyperinsulinemia is very common. I think the concept of leptin has been very clearly studied. You have various data from OB mice and DBDB mice, which are basically knockout mice, where they have looked at the leptin knockout and leptin receptor knockout. I think this may not have, I think we can discuss it in a separate thing. This would confuse the crowd.
Okay.
So this is basically on puberty and other things.
Okay, sure, thank you.
Yes, ma'am.
That there is no problem for the child, and like how long was the TLAC?
Madam, usually most of this premature TLAC, less than 2 years, it's usually benign. So we tell the mother, your bone age is normal, it's just a breast enlargement, so nothing major to be worried, but we keep them under follow. So we tell them to come every 3 months or 6 months. Usually what we have seen in practice is within 4 years, your TLAC or breast size comes down, one, or it gradually progresses to precocious puberty. Usually within 2 years, we see either they regress or they progress. So when we say come for follow-up, they usually come for follow-up, but usually bone age will give us a clue. Every year you repeat the bone age, that will give you a clue what is happening, but still if they are concerned, it could be puberty. That is a scenario we do a gonadotropin stimulation test. You do a leuprolide stimulation test, which will give you a better idea whether it's just a TLAC or precocious puberty. There are various other tests, stimulation tests which are available. We can have a very clear-cut diagnosis what exactly it could be.
No more questions. We'll move on to the next session. Thank you, Dr. Kumaravel.